Welcome back to the deep dive. Today, we're tackling a challenge that, well, it's becoming increasingly common and certainly has a huge impact in orthopedic practice. We're talking about managing patients with advanced cancer, where bone pain and the risk of pathological fractures really come to the fore. And it's more than just treating a symptom, isn't it? It's about navigating this really complex, sort of evolving landscape.
Mm.
Precision in diagnosis,
Ah,
in management, it's absolutely critical for us as mid-senior medical professionals. So our mission today is to really unpack the intricacies of metastatic bone disease, focusing on how it affects the limbs. We want to pull out those essential insights that, directly shape patient care and crucially their quality of life. And guiding us through this, well, challenging clinical terrain, we're incredibly fortunate to have Professor Mor Imam with us today. His expertise will really help eliminate these often quite daunting scenarios. Hashtag understanding the landscape of bone metastasis. So just to set the scene, could you start by clarifying what exactly we mean by metastatic bone disease? How does it really differ from primary bone cancer? And why is that distinction just so important in clinical oncology today?
yes, absolutely. It's a crucial starting point. Metastatic bone cancer, or as we often call it, secondary bone cancer. Well, it describes tumors that start somewhere else in the body, in other tissues or organs, and then they metastasize to the bone.
Right, so originating elsewhere.
Exactly. And that's the key difference from primary bone cancer.
Yeah.
Primary bone cancer actually develops from cancerous bone cells within the bone itself. It's a much, much rarer diagnosis, comparatively speaking. Now, the significance of metastatic bone disease really lies in its prevalence. The skeleton is, believe it or not, the third most common place for metastatic disease to land, right after the lung and the liver.
Third most common. Wow. Oh.
Yes. And part of the reason is the bone's very rich arterial supply. It makes it a very receptive environment for those tumor cells circulating in the blood after breaking off from the primary site. It's also vital to grasp that this isn't one single disease. It's a huge heterogeneous group. But despite the variety, they often do respond to different treatments, chemotherapy, radiation, sometimes surgery. The overall goal always is to manage the significant clinical challenges it throws up, challenges that directly and often quite severely impact a patient's quality of life.
That really clarifies it, common and impactful. So digging in a bit more, where do these secondary bone cancers typically come from? And what do the numbers tell us about incidence and maybe more starkly about patient survival?
Well, historically, and it still holds true, the most common origin is carcinomas. So we most frequently see this coming from primary tumors
Yeah.
in the breast, the lung, and the prostate. Those are the big three. But we are seeing more, arising from renal cell carcinoma, that's kidney cancer, and also thyroid cancer. And they often have quite distinct patterns when they spread to bone.
Hmm.
It's also worth mentioning non-epithelial cancers, things like hematologic malignancies, multiple myeloma, lymphoma. They can definitely involve bone. And sarcomas too, though they typically metastasize to bone quite late in the disease course.
And the survival figures, I imagine they vary quite a bit.
They vary dramatically, and that's critical when we're talking to patients. For instance, someone with lung cancer that spread to bone. Unfortunately, the median survival is typically around 6 to 7 months.
Oh, that's tough.
It is. Compare that to breast cancer, where median survival might be 19 to 25 months, maybe a 20% 5-year survival. Prostate cancer has a wider range too, perhaps 12 to 53 months median survival, 5-year survival around 25%. Myeloma, about 20 months median, 10% at 5 years. Kidney cancer, often aggressive, maybe 6 months median, 10% at 5 years. Thyroid cancer, though, often slower growing, stands out 48 months median survival, 40% at 5 years.
A huge difference there.
Absolutely. And melanoma, again, often aggressive, about 6 months median, only 5% surviving 5 years. So the variability is striking. In terms of overall incidence, one big U.S. study estimated about 2.9% cumulative incidence at 30 days, rising to 8.4% by 10 years. Prostate cancer carries the highest risk, somewhere between 18% and 29%. Then lung, renal, breast. And clinically, how patients present also varies. It might be just a single bone lesion, or what we call oligometastatic disease, just a few spots, or it could be multiple bone metastases, or even metastases in bone plus other organs like the liver or lungs. This variety really underlines why we need a tailored approach for each patient. Hashtag the mechanisms of spread and bone damage.
It is quite remarkable how these cancers, starting so far away, find their way to bone. What is it about bone specifically that makes it such a, well, receptive spot? And can you walk us through the actual mechanisms of how they spread?
It is remarkable, you're right. And the process is often explained by this concept called the seed and soil hypothesis. Basically, successful metastasis isn't just random chance. It depends on the specific characteristics of a tumor cell, the seed, and a very receptive microenvironment in the bone, the soil. The main way they get there. Overwhelmingly, it's hematogenous spread through the bloodstream.
Okay.
Although you can also get local invasion, where a soft tissue tumor nearby just goes directly into the adjacent bone. Now, if we look at spinal metastasis specifically, spread via the venous system is really dominant. Think about lung and breast cancer. They often go to the thoracic spine. Why? Because of their venous drainage. Breast cancer drains via the azygos vein, which talks directly to Batson's plexus in the spine, a network of veins without valves.
Ah, a direct route.
Exactly. And similarly, prostate cancer often goes to the lumbar sacral spine and pelvis because its drainage is via the pelvic plexus there. Its anatomy facilitating the spread. Interestingly, lung and renal cancer can sometimes spread way out to the distal extremities, hands, feet. That's often thought to be via the arterial tree, indicating more widespread systemic seeding. But coming back to seed and soil, once those tumor cells arrive in the bone marrow, really complex interactions happen. Tumor cell receptors, things like CXCR4 and ARNKL, they interact with the bone marrow stromal cells and the bone matrix itself.
And that interaction is key.
Absolutely pivotal, because it triggers a whole cascade. It leads to the release of growth factors, cytokines, things like interleukin-6, interleukin-8, and factors that promote blood vessel growth, like VEGF.
So the cancer cells are manipulating the local environment.
Precisely. This biochemical soup drives tumor growth. But critically, it also activates osteoclasts, the cells that break down bone leading to osteolysis, the destruction of bone. So the cancer cells effectively hijack the bone's own regulatory systems to create an environment that helps them thrive and spread. They coerce the bone into supporting their own destructive agenda, in a way.
That's quite an insidious mechanism actively manipulating the bone. So, given this manipulation, how do the metastatic cells actually impact the bone structure itself? Do they manifest differently? And what are the cellular processes driving this destruction, or maybe sometimes, surprisingly, new bone formation?
That's exactly right. They're active players. And when we look at imaging, we broadly classify how they affect the bone into three main types, based on appearance and the underlying cellular chaos they cause. First, you have osteoblastic lesions, also called sclerotic. These are characterized by new bone formation, although it's often disorganized. You see this most classically in prostate cancer. About 90% of prostate mets are blastic. Breast cancer can also show blastic features, maybe 60% of the time.
So they actually make bone grow.
In a way, yes. The tumor cells secrete a molecule called endothelin-1, ET1. This binds to receptors on osteoblasts, the bone-building cells, stimulating them and activating pathways like the WNT pathway. It promotes new bone formation. It's almost like the tumor is tricking the bone into building a scaffold around it. Second, we have osteolytic lesions. These are all about bone destruction, very common in breast, lung, and renal cancers. In fact, lung, thyroid, and renal mets are predominantly etolytic. On imaging, you see thinning of the bone's internal structure, the trabeculae, often with fuzzy, ill-defined margins. It looks like the bone is being eaten away. And thirdly, you get mixed lesions, showing features of both destruction and new formation. You see this frequently in breast cancer, highlighting its complex interaction with bone.
Okay. And you mentioned osteolytic lesions destruction. What's driving that specifically?
Yes. This is where we get into what's called the vicious circle of bone destruction. It's a really key concept. It starts with tumor cells secreting a protein called PTHrP, parathyroid hormone-related protein. This PTHrP stimulates osteoblasts to release another key molecule, NKL. NKL then binds to its receptor, RANK, which sits on osteoclast precursors. This binding signals these precursors to mature into active osteoclasts, the bone destroyers.
Right, the cells that break down bone.
Exactly. So these activated osteoclasts get to work, causing significant bone resorption, breaking down the bone matrix. But here's the vicious part. As the bone breaks down, it releases growth factors stored within it, things like TGF-beta, ILGF-1, and calcium. These released factors then feed back and stimulate the tumor cells to produce even more PTHrP.
Ah, so it literally feeds itself a cycle.
Precisely. It perpetuates and accelerates the cycle of bone destruction and tumor growth. Plus, other pro-inflammatory cytokines like IL-6 and IL-8 and VEGF also contribute, further fueling the fire. It's a really destructive feedback loop.
That vicious circle sounds incredibly damaging, and you can see how it leads to so much pathology. So with this destructive process happening at the cellular level, how does it actually show up in a patient's life? What are the key clinical signs, those red flags that should really make us think about metastatic bone disease? And what are the critical skeletal-related events, SREs, that we absolutely need to be watching out for?
Well, the most common way patients present is almost always with progressive pain or the development of one of these skeletal-related events, SREs for short. It's actually quite common for patients, especially if they're still active, to initially blame the symptoms on some unrelated knock or low energy injury. Oh, I must have just pulled
Or
something.
rationalize it.
Exactly. But a classic red flag for us is pain that just doesn't go away, maybe even gets worse, despite standard painkillers. That suggests something more serious is going on. A thorough history and physical exam are absolutely vital for spotting specific red flags. We're looking for things like night pain, often described as this dull, boring ache, comes on gradually, characteristically worse at night, sometimes waking them up.
That's a classic sign, isn't it?
It is. Unintentional weight loss is another big one. Pain, specifically with weight bearing, especially if it's new or worsening, is very concerning for mechanical instability. And of course, finding an enlarging mass in the area is a direct sign needing urgent investigation. Clinicians should look carefully at the skin over the area any sweating, tenderness on palpation, open wounds, even dimpling. And if you suspect an impending fracture or they've had an injury, initial immobilization with a simple splint can be crucial to stop a fracture propagating. Now, where does it usually happen? The vertebrae are by far the most common site. After that, the femur, pelvis, ribs, sternum, the top of the humerus, and the skull. This distribution often dictates the kind of SREs we see.
Right, so what are those key SREs?
Right, the skeletal-related events. These are the major problems that arise directly from the bone architecture being destroyed. First, as I said, bone pain, most frequent symptom. Can be mechanical pain from weakened bone moving or tumorigenic pain from the tumor itself, irritating nerves or stretching the periosteum. Next, and this is a huge concern due to potential permanent disability, is nerve root or spinal cord compression. Because the spine is the most common site, this is a really serious complication. It's an orthopedic emergency.
An emergency.
Absolutely.
Yeah.
Nerve root compression might just cause radicular pain, that sharp shooting pain down an arm or leg. But spinal cord compression, that often starts with back pain, then progresses to ling weakness, the second most common symptom. You can get sensory changes too, numbness, tingling below the level. Late signs are autonomic dysfunction, bowel, bladder problems, impotence. That's critical. Early recognition, quick workup, urgent surgical consultation, they're vital to prevent potentially devastating permanent neurological damage like paralysis. Then there's hypercalcemia. High calcium levels in the blood occurs in maybe 10–30% of cases with osteolytic mets. And unfortunately, it usually signals a poor prognosis overall. It's mainly driven by that excessive osteoclast activity stimulated by PTHrP, releasing too much calcium from the bone.
And how does that present?
Symptoms can be vague nausea, poor appetite, abdominal pain, constipation, changes in mental state like confusion or lethargy, even coma. It needs immediate hospital admission and IV fluids to bring the calcium down. Pathological fractures are another major SRE. The weakened bone breaks with minimal or no trauma. Constant pain is typical beforehand. Spinal fractures are often worse sitting or standing. These fractures cause huge problems, severe pain, nerve issues like sciatica, pelvis fractures, deformities, immobility. They happen at presentation in maybe 30% of patients, and crucially, 90% of them need surgery. They almost never heal on their own.
They don't heal. That's critical for planning.
Absolutely. We can't rely on biology to fix it. And finally, myelophysis. That's symptomatic anemia because the metastatic cells infiltrate the bone marrow and crowd out the normal blood-forming cells. In late stages, you can get pancytopenia, low levels of all blood cells. All these SREs just devastate a patient's quality of life and independence, which is why catching things early and intervening thoughtfully is so incredibly important.
That's a really clear picture of the clinical impact and just how devastating SREs can be. So given all these symptoms and potential complications, how crucial is getting an early diagnosis? And what are the sort of standard pathways and tools we use to confirm metastatic bone disease, especially if we don't know where the primary cancer is?
Early identification is absolutely paramount. It's not just for accurate staging or predicting prognosis, though that's important. It's mainly for getting timely prophylactic measures and treatments in place. Doing that early can significantly reduce morbidity, prevent those awful SREs, and often extend a patient's functional life, their quality time. The approach really demands a complete workup before any major intervention, especially if someone presents with a pathological fracture. Because remember that bone metastasis might be the very first sign of an unknown primary cancer. We see that quite often. Or it could be in someone with a known cancer history. So if the primary is unknown, or if the patient has a history of multiple different cancers, a biopsy is essential. Absolutely essential. Before we even think about planning surgery, it's a fundamental rule. Don't operate on a bone lesion without knowing what it is through a tissue diagnosis.
That makes perfect sense, biopsy first. So, once we suspect metastatic disease, what are the main imaging tools we reach for? Can you walk us through the strengths and weaknesses of each one, from simple x-rays up to the more advanced nuclear medicine scans?
Certainly. Each one gives us a different piece of the puzzle, and we often use them together to build the full picture. Plain radiographs, x-rays are usually the first step for someone with focal bone pain. We use them to check out suspicious areas seen on a bone scan or to look for obvious fractures. They're best at seeing osteolytic lesions, the destructive ones. But here's the catch. A lesion often needs to be quite large, maybe over a centimeter or two, and have destroyed over 50% of the bone mineral content before it even shows up clearly on an x-ray.
So, a normal x-ray doesn't rule it out then.
Not at all. Lytic lesions look like areas of decreased density, maybe fuzzy edges. Sclerotic lesions look denser, more nodular. X-rays can help monitor progression or healing. Seeing sclerosis increase can be a sign of response to treatment. But their main weakness is poor sensitivity for early or subtle disease. Computed tomography, or CT, is much more sensitive than X-ray, maybe around 74%. It gives excellent detail of both the cortical shell and the internal trabecular bone. Great for seeing both anochlytic and blastic lesions.
What are the advantages of CT?
Several. It can help with staging cancer elsewhere in the body at the same time. It lets us objectively measure bone density changes using Hounsfield units, which helps assess response. Ribs are much better seen on CT. And it's incredibly useful for preoperative planning, especially in tricky areas like the shoulder or pelvis. We can get 3D reconstructions to guide surgery. Magnetic resonance imaging, MRI, is really the gold standard for looking at soft tissues and bone marrow. It has very high sensitivity, around 95%, and specificity, maybe 90%, for detecting bone mets.
Better than a bone scan for early detection.
Yes. A key advantage is it can detect marrow involvement before the bone structure itself changes enough to be seen as a blastic lesion, so it picks up disease earlier. It's also safe in pregnancy and absolutely crucial for assessing suspected spinal cord compression. It shows the relationship between the tumor and the nerves perfectly. Metastases typically look dark on T1-weighted images, replacing the bright fatty marrow, and bright on T2-weighted images, indicating water content like edema or tumor cells. Whole-body MRI is also becoming more common, highly accurate for early detection, especially in areas rich in red marrow like the spine and pelvis. Then we move to nuclear medicine scans. These use radioactive tracers that are taken up by bone. The skeletal scintigraphy, or bone scan, using technetium 99-meter MDP, is the workhorse. Scans the whole skeleton, very sensitive, maybe 78% for early diagnosis. It's great at detecting osteoblastic activity. Areas of increased bone turnover show up as hot spots.
But it has downsides.
Big ones. Low specificity. A hot spot could be arthritis, infection, a healing fracture, anything causing bone turnover. It can't reliably distinguish benign from malignant. And it's notoriously poor for purely lytic lesions because there's no increased bone formation to pick up the tracer. Myeloma lesions, for example, are often cold on a bone scan. SPECT imaging, also using TC 99-meter MDP, gives us cross-sectional images, like CT. This provides better anatomical localization and improves specificity to around 91% compared to the planar bone scan. PE scans, using tracers like 18F FDG, glucose analog, or 18F sodium fluoride, NAF, reflects bone production, identify METs based on metabolic activity. PE generally has better spatial resolution than bone scans or SPECT. 18F NAF PET in particular has shown substantially better sensitivity and specificity than bone scan and SPECT. It's a very powerful tool. And finally, we have hybrid imaging. Combining of modalities is key. For example, 18F NAF PET CT fuses the metabolic information from PD with the anatomical detail from CT. It gives fantastic sensitivity close to 100% and specificity around 97%. You see exactly where the metabolic activity is located. Other useful hybrids include SPECT-CT, PET-CT, and even PT-MRI. They all help give us the most complete picture to guide diagnosis and treatment.
That's a fantastic run-through of the imaging toolkit. It really shows how layering these techniques gives us a clearer picture. Beyond the scans, what about lab tests? What blood work helps in the diagnosis? And crucially, when is that biopsy absolutely essential, especially when the primary cancer isn't known?
Lab investigations definitely play a valuable supporting role, giving us systemic clues. Routine bloods like a complete blood count, CBC, and a comprehensive metabolic panel are standard. The CBC might show anemia, low platelets, or even pancytopenia in late-stage disease, indicating significant marrow involvement, often a poor sign. Serum calcium and alkaline phosphatase can be elevated because of the bone destruction, the osteolysis. While specific bone turnover markers are still researched, things like tartrate-resistant acid phosphatase can be high in breast and prostate cancer mets.
Are there specific tumor markers too?
Yes, depending on what primary we suspect. We check PSA for prostate, CA-125 for ovarian, CA-19.9 for pancreatic biliary, calcitonin for medullary thyroid cancer, CEA for colorectal or breast, plus thyroid function tests. And it's really important to screen for multiple myeloma, which can look very similar. So we do serum and urine protein electrophoresis, SPEP, UPEP, beta-2 microglobulin, C-reactive protein. Even simple urinalysis might show blood, pointing towards a kidney primary. Now, the biopsy. This is often where we get the definitive answer, and it's absolutely critical. You must get tissue confirmation if the patient has an unknown primary cancer, or if they have a known cancer history, but haven't had bone mets before. We also strongly consider it if someone has a history of multiple different cancers. We need to know which cancer has spread to the bone to guide the right systemic treatment.
And what does the biopsy tell us?
The histopathology, under the microscope, might show characteristic features, like epithelial cells clumped together. Then we use immunostaining special stains like keratin, CK7 for breast lung, TTF1 for lung to help pinpoint the origin. For breast cancer, checking the hormone receptor status ER, PR, HER2/neu is essential for guiding medical therapy. Imaging, as we discussed, helps us pick the best, safest spot for the biopsy or guides the needle biopsy accurately. But the bottom line, I can't stress it enough, is you should not proceed with major surgery on a bone lesion without a tissue diagnosis first. It prevents mismanaging something else entirely.
Such a crucial point, tissue is the issue. So with all these diagnostic tools, what other conditions might look like bone metastases? What's the thought process for telling them apart, especially when things aren't straightforward?
That's a really important question because the differential diagnosis can be quite wide, and it often depends on the specific bone involved and the patient's history. But the main things we need to rule out include primary bone sarcoma, totally different treatment, multiple myeloma, the blood cancer causing lytic lesions, primary malignant lymphoma of bone, even secondary sarcoma that can arise after radiation treatment years later.
And non-cancerous things.
Absolutely. Osteomyelitis bone infection can look very similar with pain and imaging changes. Then there are non-tumor conditions like myositis ossificans, certain metabolic bone diseases, osteonecrosis, especially around the hip, or synovial proliferative diseases.
So how do you differentiate, say, an osteoporotic fracture from a metastatic one?
That's a common dilemma. On imaging, a key difference can be the cortical bone. In osteoporosis, the cortex might be thin but is usually intact. With metastatic cancer causing a fracture, you often see destruction of the cortex itself, a moth-eaten or permeative look. But clinically, a low-energy injury combined with any of those SREs we talked about, especially that persistent night pain, weight loss, pain on weight bearing, that should heavily point you towards metastatic disease over a simple osteoporotic fracture. The presence of those red flag symptoms is really key in steering the diagnosis away from benign causes. It's about integrating the imaging, the labs, and that detailed patient history. Hashtag prognosis and risk assessment.
Understanding the likely prognosis is just so vital, isn't it? Not just for our planning, but for having honest conversations with patients. What are the main factors that influence survival when cancer has spread to the bone, and how do we actually assess that critical risk of an impending fracture?
Predicting outcomes is indeed a crucial part of management. It guides everything we do and how we counsel patients. Several things strongly influence survival. Simply having skeletal metastases is generally a poor sign, but having visceral metastases spread to organs like the lung, liver, or brain is even worse. The number of metastatic sites also matters. More sites mean poorer prognosis. Visceral mets are often seen as indicating an irreversible stage, shifting our focus much more towards palliation. The primary tumor type is a massive factor, as we saw with those survival stats earlier. Lung cancer mets might mean months. Thyroid cancer mets could mean years. That difference drastically changes our treatment intensity.
Are there specific factors within each cancer type?
Yes. For breast cancer, things like other non-bone mets, the time since initial diagnosis, disease-free interval, performance status, hormone receptor status, age, and tumor grade all play a role. For prostate cancer, performance status, non-bone mets, and how markers like alkaline phosphatase and PSA respond to treatment are key predictors. In multiple myeloma, levels of beta-2 microglobulin and C-reactive protein are major independent factors. High levels mean much shorter survival than low levels. Other tumor characteristics matter too. A very large tumor, say over 12 centimeters, or a poor response to initial treatment, meaning lots of viable tumor left after chemo, predict worse survival.
Are there tools to help estimate survival?
Yes, we use predictive models, like the Bayesian Belief Network. These take clinical data and calculate survival probabilities, often at 3 months and 12 months. This is incredibly helpful, particularly for surgical decisions. If predicted survival is less than 3 months, major surgery is generally off the table. The focus shifts entirely to comfort care, often hospice. If survival is predicted between 3 and 12 months, we might favor less invasive procedures with quicker recovery. But if predicted survival is over 12 months, we can consider more durable, complex reconstructions aiming for longer-term function. One study, by Bauer, found survival after fixing a pathological fracture was often less than 6 months, similar to just getting radiotherapy for pain, highlighting how advanced the disease often is by then. It's also true that a single solitary metastasis generally carries a better prognosis than multiple mets, sometimes even allowing for treatment with curative intent.
That's a very practical way to use prognosis in decision-making. And preventing those fractures is such a key goal. What tools or scoring systems do we actually use to predict the bone's mechanical strength and fracture risk? And importantly, how reliable are they in the real world?
Preventing pathological fractures is definitely a major objective. The most widely used tool for long bones is Mural scoring system. It scores 4 things: the site, upper limb, lower limb, or the high-risk paratrochanteric hip region; the pain, mild, moderate, or functional weight-bearing pain; the lesion type, blastic, mixed, or lytic being weaker; and the size relative to the bone's diameter, less than 13, 13/23, or over 23 cortical destruction.
And how does the score translate to risk?
A total score of 9 suggests a 33% fracture risk, a score of 8 suggests 15%, and 7 or below is about 4%. Generally, a score of 8 or 9 often triggers a discussion about prophylactic fixation surgery to prevent the fracture. However, Mural score, while common, has significant limitations. Its sensitivity is okay, maybe 80–90%, but its specificity is often quite poor, only 30–35%. That means it can miss some high-risk lesions, but more often it might overpredict risk, potentially leading to surgery that wasn't strictly necessary. It doesn't fully capture the nuances of mechanical stress or overall bone quality.
So clinical signs are still important.
Absolutely paramount, often more important than the score. Excessive pain, especially pain that gets worse with weight bearing or comes on suddenly, is a huge red flag for an impending fracture. And a classic sign for an impending hip fracture is seeing an avulsion of the lesser trochanter on X-ray. That little piece of bone pulls off because the underlying bone is so weak. We also have to remember X-rays aren't sensitive enough early on. You need significant bone loss to see it. The patient's symptoms are key. There's a newer and importantly more accurate method called CT rigidity analysis, or CTRA. It uses CT scan data to directly measure bone density and geometry at the weakest point. It estimates the bone's resistance to bending, twisting, and axial loading.
How does that compare?
It compares the results to normal bone data, matched for gender and size. If the calculated rigidity is reduced by more than 35%, that indicates a significant fracture risk. Studies show CTRA has better sensitivity, specificity, positive and negative predictive value than Mural score. It's a more objective and reliable tool, though it does need specialized software and expertise to perform. #HAG comprehensive management strategies.
It's so clear that managing this is incredibly complex, needing careful coordination. How do we structure the overall therapeutic approach? And why is that multidisciplinary team, the MDT, just so fundamental to getting the best outcomes, especially when balancing survival and quality of life?
You've hit the absolute core principle. Managing bone metastases demands an interprofessional, multidisciplinary approach.
Right.
It's just too complex for one specialist alone. The team usually involves the orthopedic surgeon, often an orthopedic oncologist, radiologists interpreting the scans, radiation oncologists, medical oncologists managing the systemic cancer treatment. But crucially, it also includes pain management specialists, social workers, and often hospice nurses, especially thinking about the patient's whole journey and quality of life.
So what are the main goals of this team?
The overarching goals are really focused on preserving the patient's quality of life, controlling their pain effectively, minimizing those skeletal-related events, and achieving local tumor control where we can. Every decision weighs up multiple factors. How widespread is the disease? What's the patient's overall fitness, their performance status? What's the assessed fracture risk? And what are the potential side effects of any treatment we propose? The focus has to be ensuring the patient has a decent quality of life. Many are frail, many have a terminal diagnosis. So we have to be careful to avoid unnecessary tests and procedures that just add burden. For many, comfort care or hospice becomes the most appropriate and compassionate path, especially given that the prognosis for widespread bone mets is often limited historically 4 to 12 months. Although, as we've touched on, new systemic treatments are starting to push that time frame out for some people, which brings its own set of challenges for longer-term management.
That collaborative approach sounds essential. Let's break down the non-surgical options within that MDT framework. What are the main medical therapies and radiation techniques we use? How do they fit into the strategy for pain relief and controlling the disease?
Non-surgical management is a huge part of the picture, especially as palliation and quality of life are often the primary goals. Pain control analgesia is obviously a major focus. We usually start with NSAIDs, then titrate up or add narcotics like opioids as needed to keep the patient comfortable. Glucocorticoids, steroids can sometimes help with pain, maybe by reducing swelling around the tumor, but their use needs careful MDT discussion due to potential side effects or impact on biopsy results. Bone-modifying agents are crucial. These are the osteoclast inhibitors. They significantly reduce SREs and help with bone pain, decreasing overall morbidity. The two main classes are bisphosphonates like pamidronate, zoldronic acid, and denosumab.
How they work differently.
Bisphosphonates reduce bone breakdown and associated hypercalcemia. They cut SRE risk by about 30–40%. A key potential side effect is osteonecrosis of the jaw, so dental checks are important. Some also have direct anti-tumor effects. Denosumab is a monoclonal antibody targeting ARNKL, that key signaling protein. It's actually been shown to be superior to zoledronic acid in preventing SREs. It directly blocks osteoclast formation. A big advantage is it's given subcutaneously and isn't cleared by the kidneys, making it a good option for patients with kidney problems. Radiation therapy, RT, is a cornerstone, especially for palliation. Local field radiation is standard for painful spots. It reduces pain in 50–80% of patients, complete relief in maybe 30%. We also use it after surgery sometimes to consolidate healing. Studies show a single dose, like 8 gray, is often just as good for pain relief as longer courses, say 30 gray in 10 fractions, though the single dose might need repeating more often.
Are there more targeted radiation options?
Yes. Stereotactic body radiation therapy, SBRT, delivers a very high-focused dose while sparing surrounding tissues. It might be used for specific spinal mets from tumors usually resistant to standard radiation, or sometimes for oligometastatic disease. For very widespread disease, hemibody irradiation, treating half the body, is an option but used less now. And then there's bone-targeted radiopharmaceutical therapy. These are radioactive drugs like strontium-89 or radium-223 that specifically target bone, delivering radiation diffusely. Good for widespread pain, especially from blastic mets like in prostate or breast cancer, or if other treatments fail. Systemic chemotherapy, of course, plays a role if the primary cancer is responsive. Shrinking the primary and other mets can reduce overall disease burden and help with pain indirectly. And finally, local ablation techniques. These are for persistent or recurrent pain after radiation. Things like radiofrequency ablation, RFA, using heat, or cryoablation using freezing. Focused ultrasound, FUS, is newer. Cementoplasty injecting bone cement, often PMMA, is vital, especially for pelvic lesions or other athletic defects. It provides immediate stability, relieving pain and improving function in about 80% of cases. And for very vascular tumors like kidney or thyroid mets, preoperative angioembolization can block blood supply, reducing bleeding during surgery and potentially enhancing pain relief.
That's a really comprehensive non-surgical toolkit. Now, for us in orthopedics, surgery is often critical, but the goals are different from standard trauma surgery. What are the main aims of surgery here? What principles guide these operations? And how do the approaches vary depending on which limb or part of the limb is affected?
Surgery is indeed a vital component, and you're right, the mindset is different. The main goals are quite clear. Treat, or ideally prevent broken bones. Relieve severe pain, reducing reliance on heavy pain meds, restore skeletal strength and stability, and ultimately help the patient regain function and independence for daily activities. A really key principle is that prophylactic stabilization, fixing the bone before it breaks, leads to significantly better outcomes than operating after a fracture. Patients have shorter hospital stays, are more likely to go home, get back to activity faster, have fewer complications, and may even live longer because they avoid the major physiological hit of a fracture. It allows us to coordinate surgery better with their systemic treatment, too.
What are the core surgical principles then?
First, that golden rule again, biopsy first, complete workup before surgery, especially for pathological fractures. Know what you're treating. Second, our fixation doesn't rely on bone healing. These lesions rarely heal. So we use strong hardware plates, rods, nails, screws, often combined with bone cement, PMMA, for immediate stability and strength. PMA lets patients bear weight sooner and improves pain relief by filling the defect. Third, a general rule is to protect the entire bone. If you fix just the lesion, it might fail above or below due to disease progression. So we often use long intramedullary nails that span the whole bone. Fourth, postoperative radiation is recommended for almost all patients starting 2–3 weeks after surgery, covering a whole surgical field and implant. It helps mop up any remaining microscopic disease, unless, of course, the patient is very near end of life or had previous radiation there. And finally, for solitary lesions, if the patient's prognosis allows, we might consider more aggressive surgery like wide excision, aiming for local cure, though that's less common than palliative stabilization.
That framework makes a lot of sense. Now, the limbs have very different anatomy. Can you walk us through the tailored surgical strategies for different areas, the pelvis, the lower limb, the upper limb, and maybe touch on the spine?
Absolutely. The approach has to be adapted to the specific site, the extent of bone loss, and the patient's prognosis and functional needs. Let's start with the pelvis. We often use the Eniken classification, zones 1, 2, and 3. Zones 1 and 3 are generally non-weight bearing, but zone 2, the acetylpolymystium area, is critical for weight bearing. Lesions here, or involving adjacent zones, are problematic. Treatment might range from curettage and cementing for contained lesions, to major reconstructions for large defects using custom implants, saddle prostheses, or even total hip replacements reinforced with pins and cement the Harrington technique if bone stock is poor. The goal is always to restore stability for sitting and potentially walking. Moving to the lower limb, the most common site, femur accounts for 75%. Pain and ability to walk are the main concerns. In the proximal femur, hip area, impending or actual fractures almost never heal. The standard treatment is usually a bipolar hemiarthroplasty, replacing the ball part of the joint, often with a long stem to bypass the lesion. If the socket, as a tabulum, is also involved, then a total hip replacement.
For very large lesions here, sometimes an endoprosthesis, replacing a whole segment of bone, gives the best stability and allows early weight bearing. For the femoral shaft, the best option is usually a load-sharing intramedullary nail, locked in place, often with cement augmentation to fill defects. It provides strong internal support. Distal femur near the knee lesions are tricky, often poor bone quality, multiple fragments. For smaller lesions, maybe plate fixation with cement. But for extensive destruction, especially involving the joint, a composite total knee replacement, essentially a large tumor prosthesis, might be needed. The tibia, shin bone, is less common. Upper tibia is managed similarly to distal femur cement, plates maybe replacement. Tibial shaft usually gets a metal rod. Distal tibia often plates and screws with cement. The foot is very rare, less than 1%, usually from lung, kidney, colon. Treatment is very individual: radiation, orthotics, maybe limited surgery, sometimes even amputation of a toe for pain control.
And the upper limb?
The upper limb accounts for maybe 20% of cases, half of those in the humerus. It's less mechanically stressed than the legs, so sometimes humeral mets can be managed non-operatively with just radiation if fracture risk is low. But they can severely impair function. For the upper humerus, large tumors might need a prosthetic replacement of the top part of the bone. These are complex ops, and function can be limited because the rotator cuff often needs to be detached and reattached. Humeral shaft tumors are usually best treated with intramedullary rods, often with cement, spanning the whole bone for stability. Plates are an option, but less common for the shaft. Near the elbow, flexible nails can work well, preserving the joint. If the tumor goes into the joint, an elbow replacement might be needed. Forearm and hand mets are rare. Lung, breast, renal are common primaries, usually treated with rods, plates, or bracing. And the scapula, shoulder blade, depending on extent, might need partial or total scapulectomy.
And briefly, the spine.
The spine is the most common site overall, but surgery is actually less common than you might think. Radiation is preferred if there's pain but no nerve damage or major instability. Surgery is mainly for neurological deficits like cord compression, ongoing pain after RT, or instability. Minimally invasive techniques like vertebroplasty, cement injection, and kyphoplasty, balloon inflation, then cement, are widely used now, often off-label, at major centers to stabilize fractures and relieve pain effectively in selected patients.
That's incredibly detailed, thank you. It really highlights the bespoke nature of these surgeries. But with such complex operations, often in patients who are already quite unwell, what are the potential complications? And how much does the patient's overall health weigh into the decision to even proceed with surgery?
That's a critical consideration. Surgical treatment for metastatic bone disease is definitely complex, and it inherently carries higher risks than routine orthopedic surgery. This is largely because the patients themselves are often less healthy. They might have multiple other health issues, be weakened by cancer treatments, maybe immunocompromised, generally more frail.
So standard risks are magnified.
Exactly. They're at increased risk of common surgical complications, which can be much more serious for them. Things like persistent pain, significant bleeding during or after surgery, infection, which is particularly dangerous if they're immunocompromised and damage to nearby nerves or blood vessels, potentially causing numbness or even paralysis. Beyond those immediate risks, there's always the chance of the tumor recurring locally or the underlying cancer progressing elsewhere. And tragically, sometimes patients can die from surgical complications or simply due to the rapid progression of their advanced cancer. Given all these potential downsides, The decision to operate is never taken lightly. It absolutely has to be a very careful, very informed, cooperative discussion. It involves the patient, their family, the surgeon, the oncologist, the whole team. We have to meticulously weigh the potential benefits, pain relief, improved function, better quality of life against these very real and significant risks. The final decision must align with the patient's overall goals, their wishes, and their prognosis, focusing on what truly matters most to them. #tag enhancing healthcare team outcomes.
So pulling it all together then, what are the key principles for really enhancing healthcare team outcomes when managing metastatic bone disease, especially thinking about the patient's quality of life across their entire journey, from the initial diagnosis right through to end-of-life care?
To really optimize outcomes, the absolute bedrock principle, as we've said throughout, is that interprofessional, multidisciplinary approach. It's got to be a team effort focused consistently on preserving quality of life, controlling pain, minimizing those SREs, and achieving local tumor control where appropriate and feasible. It's about pooling expertise for the patient's benefit. When we devise that initial treatment plan, it's critical to consider the whole picture, all those holistic patient factors. How far is the disease spread? What's their functional capacity, their performance status? What's the real risk of fracture? And what are the potential burdens and side effects of different treatments? We're constantly balancing aggressive intervention against purely palliative goals, and that balance can shift as the patient's condition changes or their priorities evolve. Pain management is a continuous thread throughout, starting with simpler analgesics, titrating up, adding opioids, maybe using adjuvant drugs, or referring to pain specialists for nerve blocks or other interventions. Keeping the patient comfortable is paramount. And crucially, we always need to practice compassionate care. Recognize that many patients are frail. Many are facing the end of their life. Unnecessary tests, burdensome procedures, these should be avoided. The focus might need to shift entirely towards maximizing comfort, dignity, and quality time. That's where key support roles become so important. Having a dedicated pain specialist involved, a social worker to help navigate practical and emotional challenges, and ideally, hospice or palliative care nurses integrated early on. They are all essential to ensure the patient maintains the best possible quality of life throughout their illness, providing both medical and vital psychosocial support. And while historically prognosis was often limited, we do need to remember that for some patients, thanks to better systemic therapies, we are looking at longer time frames now. So while quality of life remains central, planning for durable solutions and longer-term function is becoming increasingly relevant for a subset of these patients. #outro one.
Okay, let's just try and unpack all of that. What an incredibly insightful deep dive into the very complex world of extremity skeletal metastasis. We've really covered the whole spectrum, haven't we? From the insidious ways it spreads and those awful SREs, through the complex diagnostic pathways, right up to the highly individualized but always patient-focused treatment strategies. And what's really striking, I think, for us as clinicians is seeing how things are constantly evolving. The advancements in both medical and surgical approaches mean we genuinely have better options now for pain control and for maintaining function for longer. But as you stressed, it all comes back to that collaborative, multidisciplinary teamwork, tailoring everything to the individual patient, their unique prognosis, their needs, their goals. So what does this mean for you, our listeners in the medical profession? I think it really highlights just how vital it is to understand these nuances. It allows for more precise interventions, more realistic conversations with patients, and ultimately truly patient-centered care. Because the goal, always, at every single stage, has got to be maximizing that precious quality of life.
And it does raise a really important question for the future. As our systemic therapies get better and better, extending life for patients with metastatic disease, sometimes turning it into more of a chronic condition, how will we in orthopedics need to adapt our management? How do we provide even more durable, functionally robust, and perhaps less burdensome solutions for people living longer, sometimes for years, with bone metastases? That's a challenge, I think, that will really shape our practice going forward.
If you found this deep dive valuable today, please do take just a moment to rate and share it with a colleague who you think might also benefit from these insights.